Hi everyone, my name is Janik Karayeb and I'm the Health Information Specialist with Brain Tumor Foundation of Canada. Today we're just doing a re-recording of a presentation from the inaugural Join the Movement to End Brain Tumors National Conference, which occurred on Saturday, October 22nd. And today we're with Dr. Catherine Maurice, and she'll be giving a presentation on a new era in the treatment of brain tumors. Dr. Catherine Maurice completed her medical training at the University of Montreal and received her medical license in 2008. Following that, she embarked on a residency in neurology, also at the University of Montreal. With her residency completed in 2013, she joined the staff at the Pencer Brain Tumor Center to begin her fellowship under the supervision of Dr. Warren P. Mason. Dr. Maurice is starting a neuro-oncology clinic at the Pencer Brain Tumor Center to assess the neurological complications associated with various systemic cancers. She also participates in the treatment of primary brain tumors, the Gamma Knife Clinic, and the Neurofibromatosis Clinic as well. This presentation will focus on the current standard of care for the treatment of glial brain tumors, new drugs currently studied in trials and their mechanism of action, and why those recent molecules are promising for the future of brain tumors treatment. Thank you so much for joining us today, Dr. Maurice, and I'll hand it over to you.
Well, thank you so much. It's a pleasure to be here today. So I'm going to present the treatment of brain tumor, the past, the present, and most importantly, where the technology is going, where we see the treatment of brain tumors in 10 years, so the future of the treatment. First of all, what is a tumor? Well, a tumor is a proliferation of a cell, a brain cell, especially in the context of glioma, that could be an oligodendrocyte or an astrocyte that are normal brain cells that are not stopped at the point where their proliferation becomes anarchic. And the type of tumor is the type of the mother cell that will give birth to all the daughter cells that will form the tumor. So according to the Brain Tumor Registry, brain tumors are about 2% of all cancers. And the most important type of brain tumors are metastasis, if we count all the type of brain tumors. For the primary brain tumors, it will be meningioma. However, the glioma are very important, and the more severe type of glioma is also the most common one, the glioblastoma, which is the type of brain tumor that almost all hospitals doing research are trying to focus the treatment on. So for the risk of having a brain tumor, there's a lot of hypotheses. For example, the radiation. We know that the people who were exposed to Chernobyl, for example, with high-dose ionizing radiation, or who receive radiotherapy as a child, or who receive high-dose radiation therapy such as Gamma Knife, have slightly increased risk of developing brain tumors. However, this is a minority in all the risk factors causing tumors. There was a lot of speculation about infections and certain vaccines, which is very big controversy, because right now some vaccines are even given as the treatment of brain tumor, and we think that it can trigger the immune system and help the immune system to even fight the tumors. So this subject is right now very controversial and even part of the new era in the treatments. There is no clear evidence that cell phone is directly related, despite all the theories. There is no confirmation that cell phones has a frequency that will be potent enough to cause a tumor. For the head trauma, there was a suspicion that it could be related because patients with trauma can have more scans and then more radiation. However, the radiation received during scans is not sufficient to be directly associated to tumors. And I will jump right now to genetics. There is a slight proportion of patients with glioma with a family history, with some genetic mutation that run into the family, who have more risk of developing brain tumors or any tumor. However, this is once again a minority of patients, and the proof is that if we have a patient who is diagnosed with a brain tumor, we don't necessarily diagnose the siblings and the children of this patient unless we have a very strong family history of cancer that is really targeting the focus on a genetic mutation. So brain tumors are sometimes in the news because there's a lot of celebrities who are diagnosed with brain tumors. For example, the person at the right is Elizabeth Taylor. She was diagnosed with a meningioma. And we have Ted Kennedy, who was diagnosed with a malignant glioma, which are two different brain tumors. But there's a lot of people that are personalities who had this diagnosis. So here is an example of a glioma. So a glioma, the best analogy I can do is like if you're taking a handful of sand and you spread it into the grass, the sand being the tumor cells and the grass being the good brain cells. We mean by that the tumor is really infiltrative. When we look at an MRI of the brain, we see a picture. So we see shades of white, gray, darker gray, black, and it's to the doctor to interpret what is the tumor and what is the swelling or what is the scarring tissue from the surgery. And it's not that clear on an MRI. All those tissues can be confounded with each other. So there's a lot of place for interpretation. Sometimes it's very difficult, especially if we're looking at the image on the right side, to know where it ends when it starts, because we see that there is a shadow surrounding the tumor. That means that when the neurosurgeon says that they're doing a complete resection and they're taking all the tumor out, this is also very difficult because the tumor is infiltrating the brain. And what we see with our eyes is not seen with a microscope. It's not possible to know when we remove every single tumor cell. So it's really the maximum resection that we're talking about is a gross resection where we're trying to remove what is macroscopically visible as a tumor, but to try to spare all the normal areas of the brain and all the eloquent areas in particular. Here is an example of a tumor infiltrating the middle part of the brain that we're calling the brainstem. This part of the brainstem that looks like a Mickey Mouse figure is called the midbrain. This is just to represent that the gliomas can also infiltrate structures that are not accessible by surgery or that cannot be removed. This part of the midbrain, for example, takes care of all the motor functions, cerebellar function, sensory function, and there is also all the structures taking care of the awakeness and the awareness passing through the brainstem. So it's not possible to resect those structures. So sometimes when the surgeon needs to do a surgery, there is some part of the tumors that voluntarily needs to stay in place, otherwise the clinical deficit will be way too important. Just to talk a little bit about all the other parts in the treatment of brain tumor that we need to consider when we're seeing patients. There's thromboembolic events. It's not only when patients are weaker and they're more immobilized, but the tumor itself will secrete in the circulation vascular growth factor and factor that are pro-coagulating that can themselves increase the risk of coagulation. There is no guidelines at the moment to suggest that we need to anticoagulate all patients with a brain tumor because there is also an increased risk of bleeding. The tumor will produce a network of microscopic blood vessels to nourish yourself with oxygen and glucose, and those vessels are not as good qualities as normal brain vessels. So there is an increased risk of bleeding and leaking. So there is a thin balance in the coagulation control. However, we know that if a patient has a clot, there is a need to anticoagulate for usually all the time that the tumor is in place, which is usually for life. The neurocognitive aspect is very important. The tumor itself could be associated with cognitive symptoms. For example, the temporal lobe on the side of the brain on the left side is taking care of the language. The frontal lobe is taking care of all the cognitive function, such as multitasking, planning, organization, abstraction. So the location of the tumor can contribute, but also the radiation can make patients more tired. The effect of chemotherapy as well can increase the tiredness and decrease the concentration and attention. And there could be also, independently of all those factors, impact on the mood by having a diagnosis that can also impact cognition. So we need to focus on that aspect of the treatment when we're assessing patients. There is also an increased risk of seizures, depending if it's a low-grade glioma versus a glioblastoma. 60 to 80% of the patients will present as the first presentation of the tumor by seizures, Once again, there is no indication to treat if we never have an history of seizures, but as long as there is a seizure, usually the treatment will be for life, and the risk of a recurrence is very high if the seizures are not treated with medication. The treatment for brain tumors right now, the gold standard or the standard of care is surgery with the maximal safe resection, followed by chemotherapy and radiation therapy together, and then chemotherapy alone. Here I'm talking about the high-grade gliomas, grade 3 and grade 4, where I'm going to focus the rest of the presentation. The surgery is, of course, the maximum safe resection, meaning that if there are what we call eloquent areas, for example, areas taking care of the speech or motor function, we cannot remove those areas. But the maximum surgical resection for the proportion of the tumor that can safely be removed. After that, there is a 6 weeks of chemotherapy with radiation at the same time, followed by a break of about 6 weeks to let the patient recuperate, and his body recuperate to be strong enough for the second phase, which is the chemotherapy alone, for a period that is varying between 6 and 12 months. Those results are based on the STOOP trial from 2005 and 2009. In 2005, the first part of the trial was showing that radiation therapy alone was inferior to radiation therapy and temozolomide, followed by temozolomide for the treatment of malignant brain tumors, which remained the standard of care. In 2009, there was an addition to this study because it was the era of biomarkers, where we're suggesting that not only us as human beings, we have a genetic, but the tumors have a genetic profile as well. And there is a marker called the MGMT that is a promoter of the reparation of DNA. And the MGMT, when it's methylated, it means it's inactivated. The MGMT has for function to repair the DNA that was damaged. When we're giving chemotherapy to a patient, we want the tumor cells and the DNA that was destroyed to remain destroyed. So we prefer that the MGMT is inactivated so it doesn't repair the DNA that was destroyed by the chemotherapy, which is the goal. So in 2009, there was an add-on to the study showing that the MGMT, when inactivated or methylated, meaning that the DNA that is destroyed will not be repaired, are a subgroup of patients with a better prognosis and also a better response to temozolomide and alkylating agents in particular. There is also tumors with what we call a good biomarker profile, which is the presence of IDH1 mutation, 1p19q codeletion, and this MGMT that is methylated. These are very complex terms, but all of that is to mention that that when a pathologist makes a diagnosis of a brain tumor, we're relying on what is seen under the microscope, meaning the number of mitosis, which is the number of cells that are entering into division, the presence of neo blood vessels, the presence of necrosis, for example. However, if a patient can only have a portion of the tumor removed, what the pathologist will see will be just representing this proportion of the tumor and not the entire tumor. It is not clear if those tumors can be heterogeneous and have different profile and different appearance depending of their overall analysis. With the biomarkers, we're wondering if it could be even more precise to determine the grade and to determine the prognosis and the possibility of response to chemo than what is seen on the slides themselves. Right now, we know that for the next classification of brain tumors, the biomarkers will be considered as a very important factor. There is also the immunotherapies that is important in the era of brain tumors. The immunotherapy are essentially meant to boost the immune system to try to fight the tumors. We know that the gold standard chemotherapy that we're using now, which is temozolomide, has difficulty to go into the blood-brain barrier. The brain is voluntarily protected by the blood-brain barrier from that is essential to protect the brain for all the toxins that can be into circulation. However, the same protecting factor could be an impact to deliver chemotherapy. For example, we know that the temozolomide, when it's absorbed orally, only 40% of the dose that is absorbed will enter into the blood-brain barrier to access the brain itself. With immunotherapies, we're boosting the immune system, and the cells of our immune system, which are the B cells and the T cells that are activated in periphery, can go into the blood-brain barrier, and we know that they're small enough that they can pass. It's our own immune system, so the blood-brain barrier will let them pass, and they can then recognize the tumor as non-self and start attacking it. So there's various types of immunotherapies that are on trials right now in the United States, and we also have trials at Princess Margaret. So this is a very interesting hypothesis for the future. There was also a trial on a device called NovoCure that is essentially a helmet that patients need to wear. There is a battery that is connected to it. The inconvenience of this device is that patients need to shave their head and wear the device almost all day long, except the time that they're going to sleep. A lot of physicians were reluctant about this technology, but the first preliminary result showed that there was an increase in overall survival and progression-free survival that was slight but still considerable, and there's other phases of the trials that are ongoing. The only inconvenience is, as we said, it can really impact the quality of life, and in a dilemma where the number of months of survival versus the quality of life of those months is a very important decision that is a personal decision. A lot of people will not want to wear this device all day long for the year to come. So this is really a personal choice. And right now, this is not a device that we can prescribe automatically to patients. However, there's further phases of the trial that are ongoing. And who knows, maybe we're going to be surprised by those results. There are also the vaccine trials that were very famous at Duke's University in particular for some trials. There is polio strength of virus that was used for the vaccines. The vaccines were included into the surgical cavity of the tumor. And once again, we know that there is a microenvironment surrounding the tumor where our own immune system and the chemo has difficulty to access. But with those vaccines that are injected right into the tumor cavity, we think that there is a possibility of the immune system to be more efficient surrounding the area right where the tumor is, which is the area of the highest importance to attack. So far, the results of the trials were very impressive, and in the spring of 2016, the FDA said that they were going to support and to try to accelerate the process of those studies, since the first results were very promising. There is also a drug called Avastin. Avastin is not a chemotherapy. It's a VEGF inhibitor, which is vascular endothelial growth factor inhibitor. This is a complex term, but we talked a little bit earlier that the tumors were trying to create a network of small blood vessels to have their glucose and oxygen. The Avastin targets this vascular network. It's aimed to destroy the neovasculature and the microvasculature created by the tumor. And it's not destroying the tumor cells at the source, but by attacking the neovasculature, the tumor cells would die back by lack of oxygen and glucose and lack of their essential nutrients to survive. So this is an indirect way to attack the tumor. So far with Avastin, it's difficult to have this drug that is essentially covered only by private insurance at the moment. It's not covered by OHIP. The reason for that is that the biggest trial, called Avaglio, was not showing very promising results. It was showing a very slight increase in the progression-free survival, but not in the overall survival. We know and we notice in clinic that there is a subgroup of patients with a very good response to Avastin. The patients who respond to Avastin can respond for several months. However, the major proportion of patients, maybe 70%, will not respond to Avastin at all. So if we combine all the patients together, the 70% who does not respond with the 30% who will respond better, all the statistics combined will not show significant results for the overall survival. And even for the progression-free survival, that is a very slight difference. For those reasons, we wanted to target the proportion of patients that were the good responders to Avastin. Several institutions tried to resolve this question, but so far we were not able to identify any subgroup or any characteristic of the tumors or of the individual or genetic biomarker that was a common denominator to all the patients who have a better response to Avastin. For this reason, it is impossible at this point to predict in advance which patients are the ones who will respond well to the treatment. At the moment, this is a personal choice, and usually we discuss with the patients about using this treatment. However, this is usually used as a third line or a second line with other chemotherapies because it didn't show superiority to the standard of care that we already know. So this is it for the presentation. In summary, right now there's various technologies that are not chemotherapies that are the future targets for the treatment of brain tumors, mentioning low-intensity electric field such as Novocure, the VEGF inhibitor such as Avastin, but most importantly, the most important field of research right now would be the vaccine trials and the immunotherapies that revolution the treatment of other brain tumors, of other tumors such as melanoma and lung cancer. So we're just starting to have trials assessing those therapeutic options, but this is really where the future of the treatment of brain tumors is, and hopefully we're going to have results in the years to come to try to optimize our treatment and help our patients. Thank you so much for your attention, and I'm going to take any questions if needed. Thank you.